Gen NCLEX RN video based on pain management. The first question, the nurse correlates which findings to the pathophysiology of chronic malignant pain? Recent trauma, rapidly dividing cells, direct damage to nerve fibers, persisting pain with no known etiology. Here the question is asking the pathophysiology of chronic malignant pain. So something related to malignancy, you know that it is rapidly dividing cell. So this answer is also rapidly dividing cells. Recent trauma and direct damage to nerve fibers, they are characteristics of acute pain. Second question, the nurse chooses which pain scale to most effectively assess pain in an older patient with limited vision. Is it a FACES scale, numeric scale, verbal scale or visual scale? Here again moving to the question, the patient is having limited vision. So at that time of course we cannot use visual scales. Then FACES scale. FACES scale can be used with adults with expressive aphasia. So here we cannot use that. And again the best one is the verbal scale. You know that it is more effective than compared to numeric scale because in verbal scale we are just asking whether it is no pain, mild, moderate, severe. In numeric we have to give the numbers also. It will be quite difficult for the older patients to interpret and tell. Better is use a verbal rating scale. And here I would like to add one more thing. Wong-Baker scale, it is used in children. In assessing a patient's pain, the nurse asks the question to the patient, what makes the pain worse? Which aspect of the pain is the nurse determining? Is it the onset and duration, intensity, quality or aggravating factors? What makes the pain worse? The question is related to aggravating factors. If it is a question on onset and duration, he or she should have asked what is the starting point and the length of the pain. If it is related to intensity, the nurse would have asked or given a visual scale to express the pain. And if it is related to quality, the nurse should have asked whether the pain is sharp, dull or achy. So here what makes the pain worse is the aggravating factor she is asking. The nurse recognizes that the primary indication for the administration of an opioid medication is which outcome? To reduce anxiety, to relieve pain, to diminish respiratory effort, to decrease level of consciousness. So the primary or the principal indication for an opioid, when we are talking about opioid, think about morphine, which is considered as the gold standard of opioid. So opioids, they indication is the relief of moderate to severe pain. Especially these drugs can relieve postoperative pain, chronic pain of cancer and pain associated with labor and delivery. Also preoperatively we can use this for sedation and reduction of anxiety, but the primary indication is the relief of pain. The nurse incorporates which content in the teaching plan for the patient receiving Coumadin? So Coumadin, that is warfarin, that is an anticoagulant. That is one point you need to think or have in your mind when you see this question. It is important to take a stool softener to prevent constipation. Over-the-counter non-steroidal anti-inflammatory drugs may increase the anticoagulant effect of Coumadin. This medication may cause drowsiness, so please do not take it before driving. You will need to monitor your blood glucose level while on this medication. So if you are again going to this question, you will understand that Coumadin, that is an anticoagulant, and when we are giving a non-steroidal anti-inflammatory drug, that will again increase the anticoagulation effect of this warfarin. So patient should be taught regarding that. And all other things, constipation, then drowsiness and glucose monitoring, that is not related to the patient teaching for Coumadin. The nurse correlates respiratory depression and decreased gastrointestinal motility with the actions of which opioid receptor? So is it a delta, kappa, mu or beta receptor? You know that receptors are present in different sites of our body where this particular drug or it will be going and binding and action will happen. If you were thinking about opioids work by binding to opioid receptors, and these opioid receptors are primarily located either in the brain, in the spinal cord, along the peripheral nerves or the gastrointestinal tract. And there are only three types of receptors in our body, opioid receptors in our body. They are delta, kappa and mu. You need to little bit more understand about these opioid receptors. The delta receptors, they are located in the brain and peripheral nerves, and they result in mild analgesia, then little bit of antidepressant effect this delta receptors can result in, and also it can lower the respiration. So here the question is asking respiratory depression and decreased gastric motility. So gastric motility is not related to delta. Next, if we see kappa receptors, they are located in brain, spinal cord and peripheral nerves. They result in analgesia, sedation, meiosis and dysphoria. So here also it is not related to gastrointestinal motility. If you see the mu receptors, they are located in the brain, spinal cord, peripheral nerves and gastrointestinal tract. So it results in respiratory depression, meiosis, euphoria and reduced gastric motility. So the answer for this question, that is the opioid receptor that result in respiratory depression and decreased gastrointestinal motility, is mu receptors. The nurse recommends treatment with transdermal fentanyl for which patient? Is it a patient with severe pain due to cancer metastasis to bone, post-operative pain after gastric bypass, intermittent lower back pain associated with lumbar strain, initial treatment for migraine headaches? Transdermal fentanyl, it is indicated only for persistent severe pain in patients who are already opioid tolerant. Here, the severe pain is for the patient with cancer metastasis to the bone. Already the patient will be on some morphine or other opioid drugs and they will be tolerant to that. At that time only we have to go for a transdermal fentanyl. So this is the patient, and it can't be used in non-tolerant patients because that can result in fatal respiratory depression. This transdermal fentanyl, it cannot be used in children under 2 years or who are under 18 years who weigh less than 110 pounds. 110 pounds means below 50 kgs. We cannot use this transdermal fentanyl. Also, the patient who is we should not use this transdermal fentanyl in patients who are in post-operative pain or intermittent pain. We will not use this, or the pain that is a migraine headache, that is a pain that responds to less powerful analgesics. So there also there is no need for using the transdermal fentanyl. Preparing an in-service about pain management, the nurse includes which finding is the most serious adverse effect of opioids? Is it a profound sedation, suppressed cardiac automaticity, respiratory depression or hyperthermia? So the most serious adverse effect of an opioid is respiratory depression. Death following overdose of an opioid happens from respiratory arrest. So respiratory depression is the most serious adverse effect of opioid. Which statement from a patient being prepared for placement of leads for deep brain stimulation indicates the need for further teaching? DBS, that is deep brain stimulation. So what is this deep brain stimulation and how it is done, and what are the peculiarities of deep brain stimulation, you need to understand. So this deep brain stimulation is an invasive treatment option to reduce the pain. It is a non-pharmacological treatment for pain. Here, what does the person or the doctor does is a surgical implantation of brain pacemaker is done, and this pacemaker will send electrical impulses to the specific parts of the brain. This deep brain stimulation system, it comprises of three components. That is, it has a pulse generator, then it has got a lead, then it has got an extension, and this lead is placed under local anesthesia. We are not giving general anesthesia, just under local anesthesia we are placing the leads in the skull. We are drilling the skull and placing it under the skull through a hole through local anesthesia, and then this leads inside the skull that is connected to the pulse generator, and then it is connected subcutaneously, it is placed in the clavicle. The patient, the important feature in this deep brain stimulation is the patient must be awake during the procedure, that is to test the electrical impulses for therapeutic effect. So this is the reason why it is done in local anesthesia, not in general anesthesia. The patient should be awake. So here the option is, I will be awake during the procedure. That is a correct option. This procedure require me to be sedated during the procedure. No, the patient should not be under sedation. The patient should be awake. Third one is, the doctor will drill a small hole in my skull. Of course, the doctor will be, it is an invasive procedure and the doctor is drilling a hole in the skull to keep the lead. The generator can be programmed without additional surgery. That is correct. Another surgery is not required for the generator to be programmed. So here the patient, if he or she says sedation is required during the procedure, that means they need further teaching on deep brain stimulation. The nurse closely monitors the patient receiving morphine and a tricyclic antidepressant for which medication interaction. Is it a bradycardia, urinary retention, respiratory depression, or hyperpyrexia? So tricyclic antidepressant, you know that amitriptyline, then imipramine, all these things are tricyclic antidepressants. They are anticholinergic drugs. Along with antihistamines or atropine also we can tell. So what this tricyclic antidepressants and morphine, when they are given together, what happens is that morphine induced constipation and urinary retention, it can be exacerbated. So constipation and urinary retention, that is because of morphine, and when we are giving this tricyclic antidepressants, it is exacerbated. So here the nurse has to monitor for urinary retention. Hyperpyrexia, it is associated with a combination of meperidine and a monoamine oxidase inhibitor, and respiratory depression is exacerbated when an opioid is given with another barbiturate. Here the morphine is given with tricyclic antidepressants or anticholinergic drug. So at that time, urinary retention and constipation are the two things the nurse need to monitor. This is a case scenario. Mrs. Rogers is a 68-year-old African American who underwent a coronary bypass surgery 2 days ago. She reports a pain of 6/10 during shift change. She further reports lower back pain radiating to the legs. She is grimacing, rubbing her legs, guarding her incision site with a pillow and taking short, shallow breaths. She is experiencing acute postoperative pain related to cardiac surgery and non-malignant pain in her lower back. So these are the two types of pain she is experiencing. Assessment reveals gas exchange and airway clearance are compromised because of pain. Then, as is her quality of sleep, sleep is also disturbed. Her mobility is compromised. Seeing this, the nursing diagnosis the nurse formulates are ineffective respiratory function related to surgical induced tissue trauma as evidenced by shallow respiratory pattern, disturbed sleep pattern related to pain, impaired mobility related to chronic lower back pain. So the first question, what clinical manifestation can the nurse use to indicate the level of Mrs. Rogers' pain on the assessment? So here, what are the clinical manifestation that shows the pain is present for the patient? Select all that apply. A subjective report of 6 by 10 pain level, shallow, guarded breathing, short, tense response to questions. Yes, of course that shows pain. Mrs. Rogers reports she has poor overnight sleep and decreased supported ambulation. Sleep quality is also because pain is there. Facial grimacing and observed rubbing of lower back and legs by patient, that also is because of pain. But blood pressure and pulse, they will not decrease but increase during pain, and also urinary retention will be happening. Urinary frequency won't happen in the side effect of a pain medication. So the last 2 points are wrong. The nurse correlates Mrs. Rogers' clinical presentation to which type of pain? Is it an acute pain? Is it a chronic pain? Is it a mixed acute and chronic pain or a malignant chronic pain? It is not a pain which is related to cancer, so it is not a malignant chronic pain. But because of the surgery, she has acute pain and there is a chronic back pain also. So it is a mixture of mixed acute and chronic pain for this particular patient. Which pain management approach is best for Mrs. Rogers? Non-steroidal anti-inflammatory drugs and opioid medication, cold application to the back, supported ambulation and distraction, aspirin and opioid medication, heat application to the chest and back, bed rest and Reiki therapy, opioid medication, prayer and music therapy, tricyclic antidepressants, TENS and guided imagery. So TENS is transcutaneous electrical nerve stimulation. It is also an invasive treatment option. You need to think about that. So here the patient Mrs. Rogers is having a mixed type of pain. When a patient is having a mixed type of pain, so non-steroidal anti-inflammatory drugs, opioids, cold application along with ambulation and distraction, they are the best approaches. Ambulation, you know that it will address the chronic back pain and also it will decrease the complication of constipation that is associated with opioid. Already we told in the previous question, constipation and urinary retention are associated with the morphine or opioid. So here if we are ambulating the patient, that can be reduced. Then non-steroidal anti-inflammatory drugs and opioids, they are both best for mixed pain presentation. And if you are just using the non-pharmacological interventions, it will not meet the requirements. So the rest of the three won't work for Mrs. Rogers. What is the rationale for using ketorolac as the preferred non-steroidal anti-inflammatory drug to treat Mrs. Rogers? So it's both high potency and has a long half-life for less breakthrough pain. It targets both prostaglandins and leukotrienes. Does not cause respiratory depression or constipation. It has been given every hour as needed to manage. So if we are thinking about ketorolac, ketorolac is a non-steroidal anti-inflammatory drug which has got high potency and short elimination half-life. They are effective at treatment of certain things like rheumatoid arthritis and gout, and also these non-steroidal anti-inflammatory drug like ketorolac, what it does is it also blocks the production of injury-induced pro-inflammatory molecules called leukotrienes in the upper respiratory tree. Here the patient has undergone a surgery on the thorax thoracic surgery the patient had. So post-operatively, for treating the pain following surgery of lung or thorax, at that time, if this pro-inflammatory molecules called leukotrienes are targeted and blocked, then that is very good for the patient. So you need to again understand this ketorolac is a non-steroidal anti-inflammatory drug that block production of injury-induced pro-inflammatory molecules called leukotrienes. So in the upper respiratory tree especially. So here the patient undergone a surgery on the thorax. So it targets both prostaglandins and leukotrienes. Hope you understood this video. Thank you so much. Please do watch for further NCLEX RN videos.